Hi friends, this patient was a high myope. He had diffuse zonular weakness. He had just about a grade 1 nuclear sclerotic cataract. There was phacodonosis and iridodonosis which I could see during a slit lamp examination. He was also a moderately high myope, and this is the way I went about with phaco emulsification. I stained the anterior capsule because there wasn't a sufficiently good red glow. And then I went ahead and constructed the clear corneal incision. I anticipated a problem while performing the capsular rhexis because I could see that the superior portion of the lens was quite visible when the patient was fully dilated. This was the portion of zonular dialysis or weakness that I could see. I could see the equator of the lens. I started the capsular rhexis away from the dialyzed area. I used a cystotome and I gradually, carefully performed the capsular rhexis, giving sufficient amount of posterior traction in order to be able to effect the tear, because it's not easy to create the tear when there's a zonular dialysis due to the laxity of the anterior capsule. You have to give enough traction force in order to pull this capsule and create the adequate tear. In this patient, I got a capsular rhexis size of about 5 mm, which was quite sufficient. And then I did the cortical cleavage hydrodissection. I know that there is going to be a weakness of the equator of the lens, and although there is a statement that we need to put the CDR as late as possible and as early as feasible, I believe that the CDR should go in as early as possible, simply because zonular dialysis, the weakest part of the lens is the equator. And if you don't support the equator by a stretch, you're going to make this equator come into the phaco probe while you're emulsifying the nucleus. I create a small mechanical separation between the anterior capsule and the superficial cortex using a rod to sweep in that area. After which I will create further space in that particular region by putting in methyl cellulose, and then I'm going to attempt to put the CTR just before I even start the procedure. Well, this is my practice, that when I see a zonular dialysis, I always put the capsular tension ring first. There is of course a great apprehension that while attempting to do so, you may actually make the dialysis worse because the tip of the progressing CTR can snag the lens capsule. Well, this can be done by gently advancing the CTR in a stepwise fashion, using a Sinskey hook from the side port to support the portion of the CTR that goes behind the rhexis, because we don't want a stretch of the rhexis at this point, and which can lead to a tear. And you can see that it is quite easy, because this is just a grade 1 nuclear sclerotic cataract. It's quite easy to thread the CTR in. And once you've got the CTR in position, we know that this CTR is going to create a nice equatorial stretch of the capsular bag, and that's going to give me enough support. I went ahead with phaco emulsification. I probably did not end up getting a good cortical cleavage hydrodissection in this patient, although I got the initial crack and separation and a through and through chop with my first attempt. I found that it was not possible for me to rotate the nucleus. Of course, rotating the nucleus should not be done too vigorously, because this can lead to further progression of the zonular dialysis. So if a gentle attempt at rotation does not work, don't attempt to rotate the nucleus. Try an in situ kind of a chop. The lens also was quite soft, it was friable, and simply with vacuum I was finding it difficult to dislodge the fragment into the anterior chamber, but eventually I managed to get one piece inside the anterior chamber. I then performed the in situ chop by holding on with vacuum and trying to create the chop, and I found that it was quite difficult, so I then switched from a chopper to a Sinskey hook. I attempted the rotation. That was wrong because this was putting a lot of stretch on the zonules. Therefore, I abandoned the rotation procedure. tried to fragment the nucleus, remove the pieces as and when they emerged out of the bag, and then suddenly everything fell into place. Because with the irrigation fluid going into the eye, the nucleus started to become more and more mobile, and little pieces of the nucleus was caught on, aspirated and brought to the center. And then I had a huge slice of luck, because the entire nucleus then dislodged itself out of the capsular bag and then presented itself in the supracapsular space. And once this happened, the rest of the phaco emulsification was quite easy, and it went on quite smoothly, got the entire nucleus out of the capsular bag. Now this is what I'm saying: if you had not put in the capsular tension ring while attempting to remove the nucleus fragment, the unsupported equator will flop in, and then there is a very high chance that you can catch the floppy equator of the bag and create a punch hole through the equator. Simply supporting the edge of the capsular rhexis using iris hook or a capsular hook will not work. Since the bag is well centered with the CTR and there's no listing of the bag and there's no tilting of the bag, it just indicates that the CTR was enough to support this zonular weakness. The patient was a high myope. He didn't have any syndromes like Marfan's or homocystinuria that I could work out, and still there was a zonular weakness. I think zonular weakness can exist in patients with high myopia. The removal of the cortex was also a little bit of a challenge because the cortical cleavage hydrodissection did not happen too well. I must have not got into the right plane and the cortex was sticking onto the posterior capsule. The presence of a CTR also prevented the easy and facile removal of this cortex, but eventually I got all the cortex out of the capsular bag. The intraocular lens has to go into the capsular bag, so as I inject the lens, the leading haptic is pushed into the bag, and then this leaves only the trailing haptic to be flexed and tucked inside the capsular rhexis edge to go inside the capsular bag. I flex the trailing haptic slightly, push it posteriorly, and with a gentle amount of rotation I got the entire lens into the capsular bag. The patient went on to do very well. This was a post-op immediately 24 hours after the surgery. The patient's cornea was extremely clear. The patient was happy. He had an unaided 612 vision. Now 5 days later I took up the other eye for surgery, and even though we are operating on a similar eye with similar set of difficulties, things don't go identical in two different cases. This was the other eye of the same patient, and in this case I found that the capsular rhexis was more easily accomplished using a UTRAT or forceps. Although the capsular rhexis tended to be a little small, it was just about 4 mm. I decided to put the CTR in. I created the space. So this is two successive cases being done, and in both the cases I'm putting the capsule tension ring at the beginning of the procedure, even before I start any of the procedures, and you see that in both the cases CTR implantation is successful. This is not just by luck or chance that I'm able to get the CTR in, that it is highly possible if you're doing in a controlled and a structured manner the manual insertion of the CTR to insert it at the beginning of the procedure itself. You just have to get the right plane and push the CTR to the periphery. You have to create the mechanical space and separation, and then put in a little viscoelastic between the anterior capsule and the cortex. So once the CTR was in position, I was more confident with this case. And see what happens when I do the cortical cleavage hydrodissection. As I do the hydrodissection, one of the pole of the nucleus pops up and presents itself. And then I use this to my advantage. I wheel the entire soft lens out of the capsular bag. Even though it was a similar case, the way the case progressed was slightly different. Nucleus management was much more simpler when I got this nucleus out of the capsular bag by simply rotating it into the anterior chamber, and then I put viscoelastic between the endothelium and the anterior surface of the lens, And using predominantly vacuum with very low phaco power settings of just 20%, giving short bursts of phaco but mostly vacuum, was able to get the entire nucleus out. The rest of the procedure went quite uneventfully. Two important lessons I learned in this case. Firstly, implant the capsule tension ring as early as possible. Use a manual method. Get the right plane of the leading eyelet of the CTR into the capsular bag and then gently support the capsular tension ring at the point where it enters the anterior capsule, and then you can put it in place. And once you have a CTR in place, everything goes well. And the second of my great learning from this case was, remember that even though you're operating similar cases, you can have different outcomes each and every time. This is what makes surgery really challenging and beautiful. And you need to be prepared to quickly adapt your surgical technique depending on what outcomes you experience on the table. Thank you for your attention.